Hello and welcome to the Healthcare Today podcast. Our guest today is Emily Harrison, the founder and managing director of Nexus HE, a global accredited provider of independent medical education. Today we're talking about what traditional medical education models get wrong and why AI-driven personalised learning will fundamentally redefine the relationship between the clinician and the classroom. You've said that the average healthcare professional receives approximately 34 invitations per week to participate in various educational courses. Why has the industry become so good at delivering content but not so much at driving actual change?
So I think it's because content is much easier to deliver, scale, and report on than behavior change. So a webinar, module, or symposium can be planned, delivered, and measured through attendance, satisfaction, and completion rates. But those measures don't tell us whether a clinician felt more confident, changed a decision, improved a conversation with a patient, or altered their management and practice. Real change requires a deeper understanding of why best practice is not already happening, and that allows you to get to the root cause.
In an interview you did with Healthcare Today, you mentioned that established frameworks like Moore's outcomes framework miss a critical stage in that the work before education is delivered. What should educators be asking before they design a single slide?
They should be asking, what is the specific behavior or decision we are trying to change, and what is currently preventing that from happening? Too often we start with a topic. For example, we need an education on a guideline, but that is not specific enough. The real issue may be that clinicians are unsure how to apply the guideline to complex patients, or lack confidence in when to escalate care, or are working in a referral pathway that makes best practice difficult. Before designing any content, educators need to diagnose the gap properly. Is it a knowledge gap? Is it a mindset gap, a skill gap, or an implementation barrier? That step is critical because it determines whether the right answer is education, reinforcement, simulation, peer discussion, decision support, or a broader implementation strategy.
Now, much of medical education is industry funded. How do you maintain educational integrity when a RFP, or request for a proposal, comes from a pharmaceutical company with a specific commercial interest?
So you maintain integrity by keeping the clinical problem at the center. The funding source may define the broad area of interest, but the educational strategy has to be built around independently identified gaps in care. That means looking at guidelines, real world evidence, faculty insights, patient perspectives, and current practice barriers before deciding what the education should address. If the problem is designed to solve a genuine clinical problem, such as delayed diagnosis, inconsistent guideline application, poor communication, or gaps in multidisciplinary care, then it remains educational rather than promotional.
You sometimes include educational gaps in your proposals that don't necessarily align with the funder's target, calling it the extracurricular gap. What happens when you bring that to a funder, and do they ever push back?
Sometimes they ask questions, but it often leads to a better conversation. These gaps are usually not unrelated. They are surrounding barriers that determine whether the funder's core educational goal can be achieved. If a funder is interested in treatment optimization, but the patient is not being diagnosed early enough or referred appropriately, then treatment education alone will not solve the problem. Or if clinicians understand the evidence, but patients are hesitant or confused, communication becomes a critical educational gap. So when we raise these extracurricular gaps, we're not moving away from the brief. We are showing what else needs to be addressed for the education to have real world impact. And most funders usually recognize that.
Now, you funded Nexus HE specifically to solve the measurement problem. How do you measure whether education has actually changed clinical behavior?
So we try to measure behavior change by looking beyond whether someone has attended or enjoyed education. Through Gauge, our proprietary software, we design outcome measurements from the beginning. So each activity has a clear link between the learning objective, the intended behavior, and the way we will assess change. That might include pre and post education knowledge questions, but more importantly, it includes case based decision making, follow up clinical challenge questions months later, and patient care logs where clinicians reflect on what they've actually done in practice. Where possible, we also look at patient feedback or real world data signals. The aim is to move from did they understand the content to did they apply it when faced with a real clinical decision?
Now, I'm interested in the answer for this one. What have you learned from patients that clinicians weren't telling you themselves?
So, patients often reveal the gaps that are invisible if you only speak to clinicians. A clinician may feel they've explained a diagnosis, treatment options, or risk clearly, but the patient may still feel uncertain, overwhelmed, or unsure what to do next. In general, patients often highlight practical barriers: fear of side effects, difficulty navigating appointments, lack of confidence when asking questions, or not understanding why a test or treatment matters. And these are often not captured in clinical led needs assessment, but directly affect adherence, shared decision making, and outcomes.
In the US, you're able to link education to de identified electronic health data. What's the most surprising correlation that you found between an educational intervention and a change in clinical approach?
What's most surprising is that the changes are often very specific. You may not see a broad transformation overnight, but you can see shifts at key decision points. For example, more appropriate testing in a defined patient group, earlier escalation, or more consistent alignment with guideline recommended management. That is important because it shows that education can influence real clinical behavior when it is targeted enough. It also changes the way we think about impact. Success is not always a dramatic system wide shift. Sometimes it's measurable improvements in one critical decision that affects the patient pathway.
You've previously mentioned that change is initiated differently for every clinician. Some need intellectual conviction, some need practical skills, some need a single insight from a role model. How does a single educational program serve, for example, those three types at once?
So, by designing a program as a personalized learning journey, not a single linear activity, the core messages may be the same, but the route through it is different and differs depending on the learner's need. As you pointed out, some clinicians need evidence based to build convictions, others need practical tools, patient cases, or decision pathways to feel confident applying it. But others are moved by expert discussions, peer comparisons, or seeing how respected clinicians approach the same challenge. The role of the program is to create different entry points and reinforcement points so each learner can engage in the way that's most likely to shift their own behavior.
Nexus HE has an integrated automated tool called Gauge, which tracks learners over many months. What have you seen in terms of clinicians reverting to old behaviors, and what, if you know, stops that relapse?
Clinicians absolutely can revert to old behaviors, especially when the education is delivered once and then it disappears. And that's not a failure of the clinician, it reflects the reality of busy practice. People return to familiar habits when they're under pressure, when systems are difficult, or when they're not repeatedly prompted to apply the same approach. What helps prevent that relapse is reinforcement over time, revisiting the same decision through different cases, reminding learners of key practice points, giving them opportunities to test and apply learning again. Sustained change is more likely when education becomes part of an ongoing learning pathway rather than a single educational moment.
You've been previously critical of funders who scatter grants across multiple providers, creating a fragmented narrative. Big question, but if you could redesign the funding landscape, what would you do differently?
I think it's difficult to be critical because there are a lot of compliance issues and reasons why this happens to keep things independent. So I think it's more a case of finding a way to overcome the barriers of compliance whilst also being able to see that sustained change and practice drivers across multiple programs. So I think I would design funding around clear clinical goals rather than isolated activities. So it would allow us to sort of see more of a coherent educational journey. It would give us the chance to look at longitudinal connected programs where each component builds on the last, looking at awareness, confidence, application, reinforcement, and measurement. That doesn't mean one provider has to do everything, but it means that strategy may be more joined up with a shared outcome framework and a clear view of the behavior change being targeted. I think instead of changing what the funders do, it would be what the providers all consistently report back on. So the funders can then pull all of that information together and then be able to compare across multiple activities.
Now, this is a very interesting innovation that you've got coming up. You're currently developing an AI tutor that lets clinicians query your content library in real time. Can you talk about how that tool will affect the average clinician's daily life?
So the goal is to make education available at the point of need. Clinicians do not always need another full module or webinar. Sometimes they need clear, evidence-based answers to a specific question in the moment. An AI tutor can help them to navigate trusted education quickly and arrive at the content decision they need. So, for example, by asking how a guideline applies to a certain patient profile, or what factors to consider before escalation, or how to explain a treatment decision to a patient. Used properly, it would shift education from being something clinicians have to remember later to something that supports them when they're actually making decisions. And that's where I think AI becomes genuinely valuable.
You've said that for education providers to survive, the focus must shift entirely to personalization. But personalized learning at scale can be expensive and technically hard. How would you make it work without bankrupting the people trying to deliver it?
So I think the key is not to personalize everything, but to personalize the moments that matter most. You start by identifying the highest impact decisions or the most common points of uncertainty, and then build adaptive content around those. That might mean different case pathways, tailored feedback, or recommending follow up content based on learners' responses. It also means starting with pilots, proving what improves engagement or behavior, and then scaling that part that works. Personalization should not mean building an entirely bespoke program for every learner. It should mean using data intelligently to make the education more relevant, efficient, and more likely to change practice.
Emily Harrison, thank you so much for your time.
Thank you very much.